We go on to our next speaker, Dr. Priti Udhay, who is an orbital and ophthalmic plastic and reconstructive surgeon from DRR Eye Care and Oculoplasty Hospital, Chennai. And she's going to be talking on complexities made simple with navigational surgery and patient-specific implants. So on to you, Dr. Priti.
Good evening to all of you. It's a real honor to speak on this, my favorite topic. And thanks, Dr. Chitra, for this wonderful webinar. So I would like to simplify this complex topic, which is navigational surgery and patient-specific implant. I have no financial disclosure. So when we talk about navigation guided surgery or patient-specific implant, here we are talking only about complex fractures. It is not useful for very simple fractures. So these fractures are complex, they are comminuted, and usually there is a secondary reconstruction involved. That is, the patient has had injury previously. There is malunion, there is bony callus formation, there is bony resorption. So it's a complex situation. And in these situations, we need to plan the case preoperatively. Now, about 10 or 15 years back, when we used to plan these cases, we used to make these kind of 3D skull models because we didn't have any other technology at that time. And we still make these models, but this was only available. This was the only thing that was available a few years back. So here now, first picture, you can see that the zygoma is malunited. You will feel that why not just move the zygoma and plate it? It's such a simple case, and why do you need technology? But what happens in these late cases is that there is malunion, there is callus formation. So this gap will be increased in some cases because of bony resorption. Sometimes there is new bone formation. So when you place the bone back, you don't know exactly where to place. The bone not only moves from lateral to medial side, but it also moves in this direction and it rotates. And this rotation is very important. Then only you will get this anterior projection in place. So for all these to be perfect, you need some kind of guidance during surgery or preoperatively. Also on these models, we could plan the surgery. Like in this case, there is a callus. So we remove the callus and we contoured the implant on this. And this contoured implant then we use for reconstruction. So when this implant fits well during surgery, you know that your reconstruction is complete. Now, a step ahead in the planning was using mirrored skull models. So here the patient's right orbit is injured. We have mirrored the left orbit onto the right orbit and made a skull model of that. And we have contoured the implants on this mirrored model. So these implants will be used during surgery. So during surgery, after you have reconstructed, if these implants fit well, you know that your reconstruction is okay. So these are indirect ways in which you know that you are doing well during surgery. But how exactly do we know that our implementation is correct? Now, that is where navigation guided surgery comes into play. So navigation is like GPRS in the car. In the GPRS in the car, you know where you are located and you also know where you want to go, the direction also, and also your destination. So same way in this navigation, you have an infrared camera on the console. You have this eye tracker, which is fixed on the skull model, and which is fixed to the skull of the patient. And you have this navigation pointer in your hand. You do the surgery normally as you always do. Whenever you're in doubt, you use this pointer and place it on that doubtful area, and you can see that area in the axial, coronal, as well as sagittal views on the pre-op CT scans that you have uploaded on the navigation platform. So it is as simple as that. You just have doubts during surgery, don't know which bone, where you are, how backward you are, how much bone is left behind. All that you can know by using navigation. And also in navigation, we mirror the other side onto the injured side. So you can use that mirrored image as a template for reconstruction. So this is how the navigation setup looks like. It takes about 15 to 20 minutes extra to set it up. And this is how mirroring works. So this orange line is the mirrored line. And when you're putting the implants, you should see that the implant coincides with your mirrored image so that you have some kind of guidance during surgery, because you don't have the other side exposed. Other side bones are not available for comparison. And therefore, intra-op navigation helps you. Also, you can virtually place your implants in the navigation platform, and you know pre-operatively itself whether this implant will fit well or not. So all this was useful some years back because this mirroring technology was available only on the navigation platform. However, now this mirroring technology is available even with the PSI companies, and therefore the use of navigation now in the current situation has become much lesser, because you can plan very well using the mirroring technology even without using intraoperative navigation. And if your planning is good, then your execution will be 100% good and you don't really need an intraop guidance. Now, in this patient, you can see that the size of the ready-made implant is not adequate for this patient, and this patient needs a patient-specific implant. So for patient-specific implant planning, we use a mirrored image, okay? So this mirroring technology you use with the PSI companies. You sit with them in Zoom meetings and we various planning sessions we have, in which the surgeon can guide the manufacturer as to how big you want the implant, what is the size of the mesh that you need, where do you want the screws, what is the direction of the screws. All this can be planned and you can design specific implants for the patient. Now in India, we have good patient specific implants at reasonable cost available, very much. Now, whenever you, as I told you before, navigation as well as PSI, you're going to use only for complex fractures, for secondary reconstructions. For localizing small bony fragments, navigation is useful, and also for bony reconstruction post resection for malignancies. So if you see the entire indication, it is more for bony reconstruction and not for soft tissue reconstruction, because we are using the pre-op CT scan of the patient, and therefore during surgery, the soft tissue is going to move. So soft tissue guidance will not be good with navigation. So here you can see I'm touching the lateral canthus, and then you can see that lateral canthus on the CT scan of the patient. So similarly, you can see various bony landmarks during surgery. And also you can verify implant placement like this, that I'm running the navigation pointer over the implant once I have placed the implant. And you can see it is coinciding with the blue line, which is the mirrored image. So your second procedure rates reduce once you use navigation. Now, few cases like this patient has 3-wall fracture, floor, medial wall, and roof. He also has ptosis, he also has telecanthus. So here, if you just put a shell like this, prosthetic shell, it will look like this because the foundation or the bony framework is not in position. So even if the patient has a non-seeing eye, if you want a good cosmetic outcome, you need to reconstruct the bony framework. So here we have used the skull model. We have recontoured the implants as well as used navigation. So two ways of checking that your reconstruction is adequate. And in these kind of cases, there is a big empty space between the medial wall as well as the floor. You won't know exactly where to place this transition zone between the floor and the medial wall. And navigation or pre-op planning helps you to do that. And once your reconstruction is perfect, your cosmetic outcome will be good. So it helps you to position the transition zone well in these cases. Now, another case where there is a malunion of zygoma. This patient has had surgery before, but you can see zygoma is still rotated. The floor is still fractured. So in this case, again, we have recontoured implants on the mirrored skull model and also use navigation. And you can see that the reconstruction is now perfect. So accuracy and precision increases when you do these kind of virtual planning. Now, another patient, very, very large gross enophthalmos, very large floor and the medial wall fracture. He also has had a reconstruction before. So this is how you plan for a PSI. You just sit on the Zoom meeting and then you plan the whole implant manufacturing with the manufacturer. And this is multiple sessions you have, so till you are really satisfied. This is one of the earliest PSIs in India that we had planned, and you can see on the screen it looks beautiful. But when you actually receive the implant, it's so huge, and it was very difficult to place this implant for this patient. And also the quality of the titanium, the quality of the surface polishing matters a lot in these kind of cases because these are young patients where fibrosis is very high. And you can land up with orbital adherence syndrome if the quality is not good. So this patient, after the PSI, his enophthalmos improved, but he had a whole range of soft tissue issues. So he underwent about 6-7 surgeries, and finally we could bring him to this level. So you must tell these patients that they need multiple stages. I tell them definitely you will need 3-4 stages in the beginning itself so that the patient is prepared. Another patient who has a prosthetic eye, again, we have designed a PSI and also did his eyelid. So I do the bone as well as soft tissue together in most of the cases, except in the lower eyelid where I do it in 2 stages. Now, so the results are good. Now, another patient, you can see there is flattening of the midface, like Aditi was saying, the anterior projection is lost. Again, there is a zygoma fracture, but now his zygoma is itself deformed completely. So if you're going to break the zygoma and move it in place, somewhere or the other, the deformity will persist because the shape itself is altered. So in these kind of cases, we design an onlay implant. On top of this bone itself, you place another implant, which is made of PEEK. So this green color is the PEEK implant that we have designed. And for the floor and the medial wall, I have used a pre-contoured striker implant, which is Medport coated. So I like to use these coated implants in patients who have had reconstruction before, who already have a plate inside. When you again go into this orbit, again fibrosis is very high, and therefore Medport coated implants are much better. So this is how here I am drilling holes in the peak also, because I'm doing a mid-face lift along with the peak implant. So peak looks like this. It looks almost like a bone, and this is the Medport coated titanium implant. And you can see post-operatively, his mid-face has improved tremendously. He needs a ptosis correction, which we will do in the second sitting. Now, another patient, again, the midface is flattened here because the zygoma is malunited. He also had neurosurgery before. You can see all the four walls are fractured here. Again, we have designed a PSI for the rim, and the floor and the medial wall was corrected by Medport coated titanium implant. You can see the implant here, and this is how the peak looks like. Post-operatively, peak will not be seen on the CT scan, but titanium is seen well, and you can see the midface has improved very well. But this
Doctor, 1 minute more.
Yes. Yeah. And this deformity is there because of the temple hollowing, which we will do a fat graft later. Now, another patient, all four walls involved. What we have done here is not used any patient-specific implant, but we designed a drill guide for him. So this is the guide that we have designed. So this will guide you as to where the drill holes should be. And if the drill holes fall well in the correct position, you know that your implant is in the right place. Now, one more advancement is we have now designed drill guides as well as cutting guides by using this virtual planning. So this was the post-op result of this patient. Now, another patient, very, very severe trauma. He's had 4 surgeries in the past. The first surgeon has put a rib graft to correct the zygoma, but you can see that the zygoma is very much laterally displaced. Now, here the second surgeon, instead of moving the zygoma, has added a PSI here. So orbit has become okay, but his horizontal width has increased because the zygoma is out. So now here we need to break the zygoma, that is do an osteotomy and move the zygoma in place. But we don't know how much to cut and how much to move. So for that, we have designed a cutting guide. So these cutting guides are then virtually planned. These are made of titanium. We fix these cutting guides and then you cut the bone. And also this is the drill guide for the zygoma. And we first drill these holes and then remove these guides, cut the bone, move the bone to the normal position, and use these patient-specific titanium plates. So this is another advanced planning where we are now having guidance even in cutting as well as in the drill holes. And this was the post-op reconstruction. You can see the zygoma now is back to the normal position, and also the orbit looks much better. And this is just 2 weeks post-op. You can see the midface has improved tremendously. We have not touched his eyelid. That I will do in the second sitting. So now another girl like this who has a very gross enophtalmus, she's had 4 surgeries in the past. So all these cases that I'm showing you have had at least 4 or 5 times reconstruction done already. But you can see posterior orbit, the volume is still very much enlarged. So now we are collaborating with a German-based company because I want a better surface of the implant for her. She already has orbital adherence syndrome. So this is the implant that now we are designing, and today only I finalized this plan. And here we also design the direction of the screw in which I'm going to put. So you can see this guide, the drill hole guides also available. So now with improved technology and also remote planning, we are able to access companies from different parts of the world and give patients a very, very good quality implants. There is increase in accuracy, predictability, as well as outcomes, and reduction in the second procedure rate. Of course, there is financial involvement, but if you see these very young patients, they are ready to pay because they have this deformity and they have to live with it for life. So we should have the entire package in our armamentarium, and we should be able to give them good cosmetic outcome if they can afford. And of course, it has a very steep learning curve. We've also learned over the years. Even the planning needs a lot of learning. And but we can now give good cosmetic results even for these very, very complex cases. Thank you very much for this wonderful opportunity.
Oh, it was a wonderful opportunity to hear your brilliant talk, Priti. Truly amazing. Vidya, maybe we'll just take one question. She has given us a great information. We need to go on to our next speakers. Very good talk.
Thank you.
Dr. Vidya?
You're muted, I think.
Vidya, you're muted.
Yes. Thank you so much, madam, for that wonderful talk. I don't have personal experience in PSI or in navigational surgery. So you can consider these questions as very layman's question. What happens if our navigation fails when we are doing the surgery? These are like high-stake patients. Do we have any safety net in place? Do we have any backup data when we do this?
Common. It's very common to have technology failures during surgery. We've had that, and we managed to do the case then without navigation. So surgical skills is the first important criteria when you take up these complex cases. And of course, you have to learn troubleshooting also. So when this happens, how you get back to normalcy, you should know a little bit of software. So you have to sit with the technician and learn that troubleshooting before you take up these cases. So we've gone through that learning curve. We had backup plans. But now that's why I showed you some cases where we have pre-contoured implant also. We have done the virtual planning on models also. Plus we use navigation. So that we have 2-3 backup plans. And you are rechecking your accuracy in 2 or 3 ways. So that way, I think you are saved.
Okay. And what about this PSI also, madam? Any material that we put in, they have the problems of compatibility issue. They have the problems of malalignment. Do we have the uh, technique to modify the existing one, or do we have the opportunity to place a new one? What happens to those malaligned implants?
As I am doing more and more complex cases, I have realized that titanium, which we used to think earlier as inert, is not all the time inert. It depends on the surface irregularities, the aperture size. There are a lot of issues. I'm going to present this in AP Sopras this year. So the quality of surface polishing also matters a lot. So whenever you go inside the orbit, even second time, you will expect a lot of fibrosis. And we are doing a whole series of these patients where we have found the adhesions intraoperatively. We have even recorded it. And I have my strabismologist who is also working on this, whether it's the muscle fascia which is affected or how we can avoid these kind of adherence syndromes. So we have this issue very commonly. We have tried mitomycin, we have tried platelet-rich fibrin membranes to avoid all this, but still we face this issue because the patients are very young. They have tendency to fibrose a lot. So that's why now, for whenever I go into the orbit second time, if they already have a plate and if I'm going in again, I prefer to have a smoother surface on top of the titanium. So Medpur coated titanium is a good option, but we can't customize that. So when you customize an implant, you get only titanium. So we are still working on all these issues that we have, but it is a very good idea to have a good strabismologist with you. They can really help you in correcting these small muscle imbalances post-operatively due to fibrosis.
Right.
Thank
Thank
you.
you.
Thank you so much.